بسم الله الرحمن الرحيم. طلابي وطالباتي الأعزاء، هذه ستكون المحاضرة الثانية في كورس اليورولوجي. As I told you, please be systematic all the time. Whenever you will be in an interview, in an exam, be systematic in the answer. You will start with history, physical examination, lab investigation, and images. We discussed with you in the last lecture, in the first one, the history taking in urology, briefly actually. In this lecture we'll discuss the second step, which is the lab investigation or the investigation. In this lecture the outlines will be laboratory, radiology, and endoscopic. Also we'll discuss these briefly. It is the first line, or the simplest, let's say, lab investigation that we are requesting in urology most of the time is urine analysis or urine routine examination. Please all the time you will record the collection time, type of specimen, if it is clean catch. Please all the time it must be analyzed or examined within 2 hours. If not, it will be you need to put it in the refrigerator. Clean catch urine, midstream urine is usually which we are requesting whenever we are dealing with urology patient. As you can see in the slides, in pediatrics there is bags, special bags that can be bought to collect the urine. Sometimes if we can get some unacceptable results for the urine, I mean, we need to go for, or need to get more clean sample of urine, that we can get it either by putting in out Nelaton catheter to the urethra, or suprapubic aspiration, using a needle to aspirate urine from the bladder, from the suprapubic area. When we have the specimen or the sample of urine, you will look for different items in this, or you will record different examinations: macroscopic examination, chemical analysis, microscopic culture, and in some cases, in some conditions, we ask for cytology. Macroscopic examination, we are looking for the odor. If it is ammonia-like, usually we have in urology urea splitting organisms or bacteria. It can change the smell to the ammonia smelling, or smell will be more obvious in these cases. It can offensive smell because of inflammation with the pus, infection, fruity ketones. Color, the normal color of the, as you know, amber yellow. Colorless, to be diluted urine in the patients, which is they are drinking a lot of water. And you know, in the cases of high bilirubin, it will be yellow green and reddish in the hematuria. I am sure that maybe most of you saw before urine examination report, or urine coming from the lab. You find 2 parts in the report. One part will be a chemical examination, and the other part will be microscopic examination. Chemical examination, as you can see, you have a container which has the sticks colored with different colors. After putting the urine in a tube, you are putting the stick in the urine, and you will compare, as you can see here on the container. There is grades of urine of the colors in each one: glucose, bilirubin, ketones, gravity, blood, pH, protein, urological and nitrate. After doing chemical examination, you will do microscopic examination. If we'll give some example of urine dipstick or chemical examination, glucose, as you can see the variation with the color here, 1+. If you remember what's written usually in the reports, 1+, for example, glucose, 2+, 3+. It is coming from the colors here. Here is urine specific gravity, sorry. It will be as you can see also different colors here, starting from blue up to yellow. Blood in the urine, also in the cases of hematuria, hemoglobinuria, myoglobinuria. And here the importance of the microscopic examination is needed here actually, because by dipstick you will not be able to differentiate between these three: hematuria, hemoglobinuria, or myoglobinuria. You need to see cells by looking to urine sample microscopically. pH of urine, again you will have an idea. Protein, as in the others, or in the glucose, 1+, 2+, 3+. Also by comparing the color of the strip or the stick to the colors which is in the cover of the container. I will skip these. Nitrate, you know there is some bacteria which is converting the nitrate to nitrate, like gram-negative organisms, which is the most common etiologies or organisms that can cause UTI in urology. Here nitrate either positive or negative, it will be here. Leukocyte esterase, also that showing this showing infection, also UTI in the cases of pyorrhea, inflammation, or renal calculi. Also 1+, 2+, 3+. It will be written in the report. In microscopic examination, there is different things that it can be seen. As I mentioned in the beginning of this lecture, if you will postpone the examination of this urine, you will put in the refrigerator and you can keep it for 2 days, then you can examine it. Normal finding or abnormal findings of the microscopic examination of the urine. If usually we count it as more than 5 erythrocyte, more than 5 leukocyte is abnormal, and the presence of bacteria is abnormal. This is an example of red blood cells in the urine in high power field. This is bacteria, this is yeast. Cast also can be seen in the microscopic examination of the urine, erythrocyte cast or leukocyte cast, which can reflect the presence of glomerular disease, that these casts coming from the nephrons. This is an example of red blood cells cast or white blood cells cast. Crystals, especially it is common found in the stone former patients, crystals like urate crystals, uric acid usually, calcium oxalate, triple phosphate, amino acid, and cysteine crystals. This is an example of oxalate crystal, which is very common in urology in stone former patients. Calcium oxalate crystals. This is triple phosphate crystals. This is urate, cysteine,
Bismillah ar-Rahman ar-Rahim.
If we will see here an example,
طبيعي كنت
I
أتمنى
will give you an examples. This is urine examination. In the left side, or let's say in the right side, there is a dipstick which is showing a trace protein, as you can see, positive nitrate and positive leukocyte esterase. By looking to the this specimen microscopically, it showed bacteria, leukocyte granules, renal tubular epithelial cells. By looking to this results or these findings, what will be the diagnosis? It is acute pyelonephritis. Yes. Another example, as you can see, there is a blood in the dipstick, and microscopically malignant cells in cytology. That meaning this is mostly urothelial carcinoma. What else we can ask in urology, commonly in daily practice, in our daily practice? We are asking for renal function test, creatinine, urea, uric acid level, electrolytes, calcium, sodium, potassium. It is very commonly asked in urology. There is a lot of another investigations which we are asking for in our daily practice, but this is the most common lab investigations that we are asking about. Other investigation that we can be asked, the PSA, prostatic specific antigen, and please memorize randomly. It is up to less than 4 is normal. Now in the last publications and last updates of this PSA value, it is age related values, but from your level, remember please, it is the normal is less than 4. Okay, more than 4 there is a risk of having this patient of prostate cancer, but I will tell you later on that the PSA is organ specific, not disease specific. For this reason, there is another causes belong to prostate that can increase the value or elevate the level of the PSA, like infection, digital rectal examination, instrumentation, insertion of catheters. A lot of different etiologies or causes can increase the value of PSA. I don't know why it is not. Also, when we are dealing with infertility patients or andrology patients, usually we are asking for hormones like LH, FSH, testosterone, estrogen or estradiol, prolactin levels. And you have actually lecture which is will be about infertility, that will go through all these details when we can ask for these and other investigations that can be asked in the cases of infertility. We have also in urology tumor markers, which can be high in the testicular tumors: alpha fetoprotein, beta HCG, and LDH. This is usually briefly the lab investigation which is commonly used. Radiological investigation, as I told you, we started with history, physical examination, lab investigation. Now, if there will be in your brain, in your head, different differentials. You need to confirm it by doing, or you will reach the right diagnosis by doing imaging, or it can be either X-rays, ultrasound, CT scans, MRI. As you can see here, there is a long list of radiology investigations. Some of it was commonly used before or in the past, but now it is to be replaced by other modalities: QB, X-ray, plain X-ray, ultrasound, urography as either IVP, antegrade, retrograde, cystograms, urethograms, VCG, voiding cystourethograms, as I told you, CT, MRI, and isotopes. An example of plain cube X-ray. Cube X-ray, it is very good that it can show the skeleton, soft tissue shadow, and stones sometimes. If we know that around 80% of urinary stones is radio opaque stones, that meaning maybe we can find around 80% of the stones, we can see it as radio opaque shadow in the cube X-ray. But we'll not forget that 20% is radiolucent, that it will be missed if we'll depend only on cube X-ray. The drawback of this X-ray also that it will not give us anatomy, any information about the anatomy, and there is exposure for radiation, especially in the pregnancy. This is an example. If I will ask you what you can see in this cube X-ray, you will tell me this is cube X-ray, if it is complete or non-complete. From where you will know it is non-complete, you need to see whole body in this and whole bones at least in the X-ray. As I can see in this X-ray, cube X-ray, the symphysis pubis is not seen there. That meaning the through pelvis is not totally seen. But if you will give for me a definition which you are seeing in this X-ray, will tell me I can see, doctor, around 1 centimeter radio opaque shadow in the left paravertebral area. By then you can tell me it can be a stone, it can be ureteric stone, okay, or renal stone because it is higher. This is another example also. This is complete. About I can tell it is complete. As you can see whole pelvis. Again, there is longitudinal radio opaque shadow more than 1 centimeter in paravertebral area and left side, which can be also ureteric stone. What you can see here, again radio opaque shadow in the through pelvis, in the cavity, which is the bladder mostly. This is bladder stone. Ultrasound, it is widespread, common used investigation tool. You can find it in private clinics in any place, but the drawback of this kind or modality of investigation is operator dependent. Whenever we are talking about ultrasound, it is operator dependent, that there will be some differences between the findings which you can find it or other one can find it. The drawback also, usually it is poor in diagnosing ureteric stones, because the ureter is retroperitoneal organ, and it is most of the time it is covered or secured by colonic gases that usually you can't diagnose ureteric stone. But you can see the kidneys if you find hydronephrosis, dilatation in the pelvic cell system in the kidney, that give you an idea that there is some, or there is an obstruction distal to the kidney, in the ureter I mean. But the good thing in this, it is cheap, as I told you, widely available, no radiation, and you can use it in children, in pregnant ladies, and no problem. Here ultrasound showing hypoechoic areas in the bladder, which can be usually tumors. Here there is a stone in the ureter or in the bladder. IVP or urography, intravenous pyelogram or urography, by injecting radiopaque material to the veins. You can do sequential X-rays, scout film first without injection, then immediate film after injection. Within the first 1 minute, there is 5 minutes, 15 minutes, and then half an hour. In the scout film, it will be plain X-ray, that you can see any radiopaque shadows. Immediate film, or in the first minute film, will have nephrogram, opacification of the both kidneys. You will appreciate the uptake of this contrast both kidneys. Then 15 minutes, 5 minutes, 15 minutes, and delayed, that you will have an idea about the collecting system. As you can see here, is it normal? We can see it written normal in the slide, but maybe you can find some dilatation in the right pelvis. If you compare it, usually you need to compare both sides together. I see some dilatation in the right pelvis. Here looks like normal. If you compare the right to the left, it is good excretion, there was good function of both kidneys. And the good thing in IVP, that it can, or giving you an information about the function of the kidney. Here horseshoe kidney, as you can see, both kidneys is connected by the lower isthmus, lower pools, and lower in position from the usual location of the kidneys. And this is horseshoe kidney. Here, as you can see, no left side kidney, both kidneys is in the right side. This is crossed renal ectopia. And the thing which I need you to notice here, that the normal insertion of, or the normal insertion of the left ureter in the same side, in the same anatomical location. IVP here also, you can see here some filling defects which can show us as the polycystic kidney disease. Here, as you can see, no right side kidney. Mostly this patient lost his kidney after long years of having this PUG obstruction, or maybe he underwent nephrectomy surgery. And the left side, as you can see, ballooned pelvis, that is significant for PUG obstruction, pelvic junction obstruction. Here also again space occupying lesion in the mid-zone of the kidney. Here cobra head appearance, which is significant pathognomonic for having ureterocele. Here TB, as you can see, amputated calyces, deformities, filling defects in the ureters. It is pathognomonic for TB, tuberculosis. Here cystogram by injecting contrast inside the bladder. You can here see there is filling defect centrally or in the lower segment part of the bladder, which can be either tumor or medial lobe of prostate. Here I believe it is medial lobe of a prostate patch. Here, as you can see in this cystogram, there is refluxes bilaterally, there is diverticulum on right side, and also there is central localized filling defect that it can be also benign prostatic hyperplasia, I mean median lobe of the prostate. Yes. Here also again cystogram, filling defect in the bladder.
Bismillah ar-Rahman ar-Rahim.
Can be also
طلابي وطالباتي الأعزاء.
a clot, or it can be enlarged medial lobe of the prostate. Here as you can see, the bladder is compressed by a tumor or a mass in the pelvis. Here also looks like there is a tumor in the right side, which is obstructing the right ureter. Ascending ureterocystogram, as we told, we can inject diluted contrast material and through the urethra, and you can take films for the anterior urethra, posterior urethra, and to the bladder. In this case, the bladder is deformed, multiple diverticulums, regular outlines, refluxes. Here written P patch, but it can be as a broad terminology, neurogenic bladder, that it is diseased bladder, without looking for why it is like this. Ascending pyelography or pyelogram retrograde. We are doing this by doing cystoscopy, inserting a ureteric catheter to the ureter, and also injecting contrast material, diluted contrast material to the ureter. And in this case, you can find filling defect in the left ureter, which is clearly can be diagnosed. CT scan today, in this era of time, CT scan replaced actually the IVP, especially CT scan with IV contrast, because in one study you can have, or you can get detailed information about the anatomy, about the function, and with high definition actually. For this reason, we preferred in these days to do CT scan instead of doing IVP. But the problem is it is expensive, needs contrast, there is exposure for radiation, but it is great for diagnosing tumors, trauma, or stones. This is an example for a tumor in the bladder. This is renal mass, as you can see, left renal mass. By the end, as I told you, we are using lab investigation, imaging, and endoscopy sometimes for diagnostic purposes or diagnostic endoscopy procedures. Like in this slides, which you can see papillary tumor inside the ureter, I believe, because the lumen is narrow, and you can put the diagnosis that this is papillary lesion or tumor inside the ureter. Thank you very much.